This is David Lohr, and I'm with the University of Louisville School of Medicine, and we'll be talking about the pharmacological treatment of autism spectrum disorders. So by this point, you've already learned about the careful formulation, diagnosis, and how to evaluate comorbidity. So just like in real life, it's now time to look at some of the more specific treatments that are available for autism spectrum disorders. I have no disclosures or conflicts of interest to disclose, but I will be discussing FDA off-label uses of these medications. The objectives of this lecture are to give an overview of how to use medications in this population, and by doing so, examining the evidence case by case of the studies. Part of my rationale is to help you understand how the evidence works and how you may develop some critically reading skills to understand the importance of the evidence in this population. But starting off, remember now and at the end of this lecture, psychopharmacology is just one component of the overall treatment plan. By this point, you've done a careful formulation, and you should try to avoid being in a position where you're the only provider giving services to these children. The issues are very complicated and require a lot of therapies, and medication plays a very important part, sometimes crucial, but it should not be the only thing that you're coordinating. This slide illustrates the evidence-based practices for treatment of youth with autism. And as you can see, many of these slides come from the behavioral therapy background, and they're components of skills that need to be accomplished in order to develop more skills in terms of occupational therapy or speech therapy. But you'll see that medication is generally not felt to be an evidence-based practice, unfortunately. As such, there's really no evidence-based biological treatments for the core features of autism. What you do see that medications and other components may help with target features. So looking at psychotropic medications and how they have been used, throughout the last several years, there's been increase in use of medication in this population. Evaluation of commercial claims over the years 2001 to 2009 will show that almost 2/3 of every child has been treated with a medication, and that there's a substantial number of children who have been treated with more than one. In fact, that if you are certain, higher odds for polypharmacy do exist if you happen to be an older child, or if you have a medical or a psychiatric comorbidity, or if you have contact with a psychiatrist. Certain regions and ethnic groups are also higher risk. The study questioned the availability of how frequent families can access behavioral treatments, also raises a question about the overall evidence of polypharmacy and the need to be careful with safety and treatment planning. This illustrates graphically that almost 1/3 of children are treated with 2 or more medications, and that this is a concern that you may find in your practice. The types of medications that children with autism receive are broken down in this slide by a survey study, and the use of stimulants, antipsychotics, and antidepressants are the most common, but you also see a certain number of children with alpha agonists and mood stabilizers as well. In this study, 3 or more medications were seen in about 10%. So when you start thinking about pharmacotherapy, certain principles need to be followed. First of all, we expect that by this point you've done a careful evaluation and formulation of the case. You have considered medical and psychiatric comorbidities, and you have come to the conclusion that you have some target symptoms. Now understand there's a difference between core symptoms that reflect the diagnosis of autism, such as social reciprocal behavior or restrictive repetitive behaviors, and then target symptoms that may be targets for treatment that can improve functioning. You want to establish a hierarchy of these overall target symptoms and understand which of these you wish to try to address first. And as always, these results are better if you combine treatments with intense behavioral plans, speech, occupational therapy, perhaps physical therapy. This decision aid is for parents, but can also be useful for providers alike. This gives you some sense of the overall symptoms that may be amenable to pharmacotherapy. Things like aggression, irritability, tantrums, meltdowns, those type of things. Hyperactivity or impulsivity may also be a factor. Many times what I find is parents will come to me when they're having trouble with their child in a couple of things. It may be that they're unable to get the child to do what the rest of the family is doing or what's required at the time. So that kind of falls into fixated behaviors perhaps. But it can also be irritability and tantrums. A normal child may resist, but a child with autism may have a marked tantrum or prolonged period of anger at a similar irritability. So in this case, medication may help. When medication doesn't help are more common behavioral problems like defiance or the core symptoms of autism, which are like social reciprocal behavior, core social skills. Algorithms exist. This is an example of an algorithm for the assessment of irritable behavior. Probably in my practice, it's most common to be asked to evaluate a child who's having trouble with irritable, aggression, or just disruptive behaviors that may result. And this algorithm focuses through the steps that you should take. First of all, start with a careful evaluation and formulation. Think about the problems that might be existing. Think about safety. Does the child need to be treated in a safer condition? If not, then you may evaluate. When you're thinking about treatments, you may be the last medical provider the parents and child see before starting a medication. So don't assume that they've already been cleared medically. Look at things that are common in the areas of autism, such as constipation, sleep problems, or perhaps pain. Many children with autism may have not had a dental examination. Think about the family factors that may be taking place. Like any child, adolescent psychiatry condition, think about the family factors that are involved, family stresses that may be playing a part in what's happening. Aggression may be a function of communication. If a child with autism can't communicate their wants or needs, then you may see aggression or irritability result. So think about what service or what function aggression or irritability may be playing. So if these factors are considered, then you can identify target symptoms and identify treatments that may help. Think about next about target your symptoms, how are you going to measure outcomes, and how will you understand when you have made a meaningful difference. With most medications, also start to think about how long do I treat? When is a successful response? So moving forward, if you've done this, now I think it's time to look at the evidence. And this is where I wanted to give you a case-by-case review of the evidence for each class of medications. And first of all, I want to develop some critical skills for you. When you look at drug studies and drug trials, you may see a response being defined. But how is this response measured? Usually it comes down to a few scales or surveys that are used that can show treatment effects. And the most common of these may be the aberrant behavior checklist, which is a 58-item informer-rated scale that breaks into several subscales that can show treatment effects. The most commonly used, probably in the autism area, at least with the antipsychotic medications, is the irritability subscale. Other common scales may try to measure the obsessive or compulsive nature of autism, and they have been defined and refined for use in this population. And finally, the Clinician Global Improvement Assessment Scale may be useful. And this is really just a standardized way of saying how much has this child improved based on baseline. And based on 3 to 4 answers, you get a Likert scale response. Thinking about the medications now, I want to start with antipsychotic medications because they are the only medications that have FDA approval for treatment of irritability in autism. And much of this came from the initial study of risperidone, which one of the first large studies that looked at risperidone was a double-blind, large center study, multi-center study of 101 kids. And so this is a dense slide, and so I don't expect you to try to read this I want to jump around and point out some important clinical points. So look at the number. The overall number is 101 children. That's a fairly large sample. That's important. Look at the age group of this population, mean age of 8.8 years, so it's a fairly young group. And look at the dose. The dose is 1.8 milligrams, which is not a really high dose. So that gives you some sense of the population and the dose range that you might find. Parents report improvement on irritability and aggression. They report reductions in irritability, and 69% versus 12% had a positive response. So in this case, a positive response is defined as a 25% decrease in the irritability subscale. And you must remember that there's a difference between a statistically significant finding and a clinical significant finding. Children with a 25% reduction of irritability may still be pretty irritable, and so you may have parents still coming back to you asking for what to do next. So risperidone also has some improvement in stereotypies, hyperactivity, and some repetitive behaviors. So this is a fairly dramatic finding, one of the first ones that came out that showed medication could have an effect on autism. But please note that even after 8 weeks, you had some significant side effects on weight gain, appetite, fatigue. Risperidone also is associated with prolactin increase, and so you can find problems with breast enlargement or galactorrhea. Looking at risperidone, this graph shows that the effects can be as early as 2 weeks. You see some separation. So the takeaway point here is it may not take long for you to really see that risperidone can have a dramatic improvement on irritability. The study was so striking that the extension study that carried on from this was stopped early by the NIMH because the relapse rate in placebo was so much higher than in risperidone. 67% of children relapsed compared to 25% in risperidone. This further supported the evidence saying that risperidone could be effective for as long as 8 months to have some effect. All right? Now this study I really think is important to focus on because now we're starting to get into real life situations. You're adding parent management training with risperidone, and you start to understand a little bit about the differences. But if you can combine parent training with risperidone, you see a couple of things. You can see a decrease in maladaptive behavior, but you could also see an increase in adaptive behavior here too. So improvements in communication and compliance can be seen. And also parent training may be associated with slightly lower need for dosing. I think it's important to realize that the addition of parent training can be lowering the overall dose needed to be helpful. Aripiprazole is the second medication that we have found to have FDA approval for irritability. It comes from 2 large studies. The first is what's known as a fixed dose study, where they took a large number of kids, again 218 kids, mean age of 9.7 years, and they looked at how defined doses of Abilify helped with irritability. And they found that every dose was really helpful with irritability, but that the highest doses of 50 milligrams also showed some effect on compulsions. And if you look at these slides, you can see again that the effect is noted even within 1 to 2 weeks. It's a fairly early drastic effect you can see. The second main study that supported aripiprazole and its approval was a study that allowed for changing the dose. And so the dose range was between 2 and 15 milligrams, about 100 children. And again, improvements were noted on the irritability subscale and the overall clinician improvement. So clinicians were thinking things helped here. Aripiprazole has some advantages to risperidone. It is a mixed dopamine agonist and antagonist, so in some cases it may be better tolerated, may have less weight gain. Certainly in the children that I mentioned that may have elevated prolactin or breast enlargement, aripiprazole can be a nice choice because the mixed effects have been shown to lead to reductions in prolactin. You know, if insurance were no option, this might be the medication that I would use first line. But in the state where I practice, a lot of the children that I have are on Medicaid. They tend to prefer a trial of risperidone first. Again, aripiprazole has been studied in open label extensions, and it was effective to some degree, but In this case, they were not able to show any long-term protection against prolapse. So in summary, for the antipsychotic medications, risperidone and aripiprazole are FDA approved for treatment of irritability in autism. The improvements can be dramatic. In many cases, I can find that this keeps a child from having to go into the hospital when there's serious injury or irritability, aggression involved. The problem that I run into more often is how do you stop the medications, because they can make a dramatic improvement, and often parents are reluctant to change things once they have experienced that. So again, establish targets that you want to treat, be systematic in your dosing, try to measure the responses in a systematic fashion, and monitor side effects. Weight gain, metabolic changes are common. These medications have been associated with an increased rate of diabetes and lipid abnormalities over time. And over time, they still have an increased risk of movement abnormalities, including tardive dyskinesia. In fact, some of the more interesting study coming out lately is that metformin has been shown to be effective to reduce weight gain in autism. This is a 16-week double-blind study of 61 children with autism, 6 to 17 years of age, looking at metformin between 500 milligrams twice a day and 850 milligrams twice a day. So compared to placebo, there is a reduction in weight gain, but they did not show any reduction in cholesterol or other lipid values. And a certain number of children had side effects. Most commonly, I would think you'd want to watch for diarrhea, constipation, vomiting, and liver function enzymes in this population. This graph shows the onset and the time frame of these changes. So I would be prepared to tell parents, if you're going to use this medication, you want to be talking to them about dietary changes and exercise, as you would in all kids, but tell them that we need to commit to a 3-month trial to see if this is going to work. The next class of medications I'd like to discover are the selective serotonin reuptake inhibitors. And there are a lot of reasons why these medications might be helpful and should be helpful based on preclinical data that shows that there are elevated levels of serotonin in the blood. PET studies have shown differences in serotonin synthesis, and studies showing the serotonin transporter gene have been shown to be affected in cases of autism. And in many cases, they're used to target anxiety or repetitive behaviors. But keep in mind here again that these repetitive behaviors may not be obsessive compulsive disorder in nature. They may be more related to autism. So you may see that these medications don't work as well as as you would expect or hope. Some of the evidence for these medications come from one double-blind, placebo-controlled study of fluoxetine. And a couple of things to take from this. 39 children, so it's not a great number, relatively small, and the mean age is pretty young, 8 years. You have your standard 8 weeks of active versus placebo with a 4-week washout, so nothing really unusual there. But the mean dose is only about 10 milligrams per day. There was some evidence that there was a reduction in repetitive behavior on the child version of the white box, but there's no change in speech or social function. And they did not find changes in side effects, although there were some children who had significant agitation. So compare this with a later study that looked at a larger number of kids, almost 150 children, on citalopram. And the mean dose of citalopram was also closer to what you typically find in treatment of adolescents and children. And here this study was negative. There was no change in repetitive behavior and a strikingly high proportion of adverse effects. 97%, in fact, had some sort of adverse effect, including behavioral activation. So to this point, there really hasn't been much more data looking at this. So in summary, you have a Cochrane Library database meta-review that looks at these medications and actually finds that through their look of randomized controlled studies of children, quote, no evidence of effect of SSRIs in children and emerging evidence of harm for treatment of autism. So again, there's no improvement in core symptoms, and common side effects can include agitation, aggression, hyperactivity, insomnia. So remember the slide where antidepressants were among the top 3 medications. So It is important to understand, I think, the risk, the strengths and weaknesses of SSRIs in this population. They are being used. When I look at this, I sometimes think, well, what about the kids? We know that children with autism have anxiety. Up to 40–50% of children have defined anxiety. So in this population, could SSRIs be more effective? We don't know that answer yet. There's no data to guide us, but that is something that I think about when I see this slide. ADHD and autism coexist. ADHD is sometimes leads to the most common symptoms presenting for treatment. By this point, families may be involved in therapies, and it's not uncommon for us to receive an email or a phone call from a behavioral therapist saying, if we could just help this child calm down a little bit, maybe they could do better. And so you'll start thinking along the lines of attention deficit disorder. Epidemiological studies have shown that comorbidity does exist, and these symptoms may impair obtainable treatment gains and educational gains. So let's look at the evidence for this and see what we have. Stimulants, again, so we have a second RUP study, which is a multi-center controlled study with fairly standard design. And this one's a little bit more complicated. You're looking at a double-blind, placebo-controlled crossover design with an open-label continuation. So what they did here, they actually played around with the dose for the first week to figure out which dose might work, what dose could they take, and then they switched a low, medium, and a high dose, gave them about a week's worth each, and through systematic collection of data, they found which one worked best. And then they continued it for 8 weeks. This shows the results. You can see that baseline, these children had a large number of symptoms on the hyperactivity scale. But by the time they figured out the best dose, they dropped these down quite a bit. They continued on these doses and found that parent and teacher reports remained fairly well controlled. You can see this creeping up just a little bit, but for the most part, some response. There's another study that looks at extended release methylphenidate, only 23 kids. I didn't include this on the slide set, but it does show some positive response as well. So basically that's it for stimulants. So in summary, compared to the normal population, stimulants can work with autism, but they don't have as good of a response rate, and they have higher risk of side effects such as irritability, not eating well, poor sleep. It's pretty common that I find that I have a child that I will start on a stimulant for ADHD, and within a week, a day, you get a call saying, we can't do this. I gave the child 1 or 2 doses, and there's marked aggression. So in some cases, you figure out usually one way or the other if it's going to work. What usually works also is lower doses may be effective here. So it's important to think about other medications that may be useful for ADHD. One of these is the extended-release guanfacine, which is an alpha agonist. And you have a pretty nice double-blind study of support here that looked at 62 subjects, again, mean age about 8 years. And look at the dosing here. 3 milligrams a day is pretty good. You see that that's a fairly good dose. No real difference in the early exit versus placebo, and no real increase in serious side effects, although many children require a dose adjustment to minimize side effects. Extended-release guanfacine is not always available for the population that I treat. A lot of times I have to start with generic versions of shorter-acting guanfacine and clonidine. So for clonidine, we do have some small randomized support here that shows some improvement in hyperactivity and hyperarousal, and it's generally well tolerated. What I usually find clonidine being used for, in more cases, is its sedation effects. So you find it useful at night for sleep, and but there's no data that supports that, unfortunately. But we do have at least data that supports that it's well tolerated. And finally, atomoxetine may have the most data for ADHD and autism. In fact, some people will consider atomoxetine perhaps to be first-line treatment for this based on these 2 studies. The first one was an 8-week double-blind study that looked at almost 100 patients. And notice the dosing here was 1.2 milligrams per kilogram. And you see that atomoxetine versus placebo have a fairly nice response rate of 40.7 down to 31.6. Again, remember that any child that scores a 31.6 on a rating scale is probably going to have some significant symptoms. And working with atomoxetine can require some titration too. Now, atomoxetine has side effects, and the bottom line is that just like stimulants, the response rate is probably not as good as in the normal developing population, and you have more side effects. In this case, there's certain side effects that need to be evaluated. Nausea, poor appetite, early morning awakening may be a problem here. All right. So the next slide looks, though, at another real-life situation where you combine atomoxetine and parent training. And again, this is important for a couple of reasons, because it shows the real-life situations where atomoxetine may be effective. And breaking this down, notice a few things. That the dosing here is 1.8 milligrams per kilogram. That's a pretty high dose. And atomoxetine requires titration, so you're not going to get to this dose over the first week. It's probably going to take you a couple of weeks. In real life, you're probably going to take almost a month to get there. So it can be a little bit more challenging to work. But they also found that atomoxetine combined with parent training was effective. Now, it's not shown here, but there is some difference between parent training was important. Don't take from this slide that it's not. It was important with helping with compliance and also with psychosocial issues. They followed this up with an extension study, 24 weeks, that was important because it showed 91% of patients and families chose to remain on this medication over the 24 weeks. That's pretty good compliance. So that suggests that it is pretty well tolerated and the families were pleased with the results. In this case, they weren't able to show that parent training added benefit for treatment of ADHD, but it was helpful for compliance and other measures. So in summary, atomoxetine has both double-blind and extension level support for use in autism, and these authors concluded that atomoxetine should be considered first-line treatment for treatment of ADHD symptoms in autism. Next class of medications are the mood stabilizers, and there are a few reasons why mood stabilizers should work. The comorbidity of seizures with autism is substantial. Almost 1/3 of patients with autism will have seizures. And mood stabilizers have been shown to have some positive effect for aggression in normal populations. And finally, there's the kindling theory that looks at bipolar disorder. And the more episodes of an event can make the recurring episode a little bit stronger. And mood stabilizers are felt to stop this. However, overall, the results have been mixed with mood stabilizers in autism, and overall, they've been disappointing. This is a summary slide that looks at most of the major studies. Most of these have to do with valproic acid, and so you have 3 different studies really that looked at this. The first one showed no significant effect, and the second 2 showed maybe some hints of effect or a trend in either improving repetitive behaviors or irritability. The one caveat from the third study by Hollander showed that irritability might be available, improvement might be available if you have higher dosing. The other studies involving lamotrigine and levetiracetam were generally negative and poorly tolerated. So unfortunately, the data for mood stabilizers is not very strong. We've talked about insomnia being a problem, and insomnia is one of the biggest challenges facing youth in autism. Melatonin has shown some double-blind results. Before you start thinking about medication, so in this case, I'd want to encourage you to go to your sleep hygiene and behavioral measures to treat insomnia. Start with a comprehensive approach. Try to understand why a child may not be sleeping. Again, this could be a medical reason, such as constipation or dental pain. And then look at more typical behavioral strategies, as you would with any child, to look at scheduling, having TVs and screens taken away from the child an hour before bedtime, getting them out of the room, trying to look at any behaviors that could be rewarding a child to stay up. And so take an overall sleep hygiene approach. And once you have done this and you haven't had results, then it may be okay to try a medication. So in this case, they looked at children who had failed behavioral treatments for insomnia and looked at a double-blind study of about 125 kids. So this is a larger study. They looked at a certain proprietary type of prolonged-release melatonin, 2 and 5 milligrams. They found that it was felt to be efficacious and safe. They also showed open-label support up to a year. These children go to sleep earlier, they sleep longer and have less awakenings. The one caveat here is this is an industry-sponsored study. So we're getting into medications that have less data. One of these is N-acetylcysteine. You may recognize this from your years in the emergency room treating Tylenol overdoses, but it also has some effect perhaps in autism. It is an antioxidant, and there have been theories on the development of autism that have to do with the oxidation to environmental insults, and the excitatory or inhibitory systems may be off. These are often preliminary, but it has led people to investigate whether medicines like N-acetylcysteine would work. You have one double-blind study that showed support in 33 kids, so a relatively small number. And you looked at N-acetylcysteine at 900 milligrams a day. This can be a difficult medication to work with because it's a lot of tablets to take to get to 900 milligrams 3 times a day. So it takes a lot of commitment for a family to try this. And this one study showed, the first study showed some improvement in irritability, so a positive study, and even some improvement on autism mannerisms on the SRS. I think this may be the first study that looks at, that actually showed some, perhaps some core autistic symptom improvement. Some side effects were noted, but generally well tolerated. N-acetylcysteine is available over the counter and prescribed as well. And so you have to be careful with where you purchase this or how it's prescribed. But the next study didn't show that it worked, so it hasn't been replicated. So I think the results are preliminary. It has been studied in adults with some effect for picking disorders, excoriation disorder in adults. A recent study showed some positive results in a fairly large study. So there may be some benefit here. Other people have looked at glutamatergic agents such as amantadine, memantine, or riluzole. Although case reports and open trials may show some report, double-blind studies haven't shown effect yet. So outside of some adjunctive role, there's little data to support this. So now we're going to talk about complementary and alternative medicine. This is an important slide to consider because many families are desperate for any help they can get, and they will be anxious to try medications that may help. Word of mouth, parent groups may suggest that certain treatments are effective. So there are a lot of medications and treatments, herbal supplements that are available to families. I think as physicians, it's important for us to be aware and encourage open dialogue to understand exactly what's happening, because if you don't know what parents are doing, it's going to be harder for you to treat effectively. So these are some of the common medications that may be helpful, that may be tried in this population. Probiotics, carnitine, vitamin D3, omega-3, and CBD or cannabidiol are all sometimes used. Ask about them, try to understand what they're doing, and in some cases try to provide at least systematic guidance to help them understand if something works or not. I also included secretin as a result of a medication that was tried and used with little support many years ago until evidence finally came up that it was not felt to be effective. So in many cases, these medications, they don't have evidence supporting them or refuting them yet. So try to use your best judgment and guide the families to safety while being understanding of their need for relief. So a few finishing slides on medication management. Again, so if you're going to use medications, start with a careful formulation and diagnosis. Think about where medication falls in the overall treatment approach. Have target symptoms. Try to assess these systematically. Try to look at how well these are working. Think about where your medication treatments fit into other therapies. It's very important to be in a position where you're communicating back and forth between therapists and other providers. If you're going to use the medications, I generally recommend that you start with a pretty low dose and make changes slowly. Be sure that you know what you're doing before you increase the dose. Try to make only one change at a time. Try to minimize polypharmacy as much as you can. Monitor for side effects, and then start to think about when it might be time to lower or stop medications. We live in a real world, and not every family unfortunately, has access to all the needed therapies. So this slide is not meant to say that we shouldn't recommend behavioral therapies, but as a provider, it's up to us to continue to advocate families and to obtain services, to try to make services more available. So there are a lot of practical factors that may make it hard for a family to get needed behavioral therapy or speech therapy, insurance, transportation, school, or family factors, even finding providers available in a setting. I work often in a rural setting, and sometimes the only settings where families and children can get speech and occupational therapies is the school. So there would be pressure to treat with medication in this case. Acknowledge that and understand it, but also think about where it fits in the overall plan. But remember the evidence base and try to encourage evidence-based treatments as much as you can. So in summary, I would say pharmacotherapy can be extremely effective, but it is only one part of the overall approach. Now, if medication is going to be used in a child with autism, who is better trained to do this than a child and adolescent psychiatrist? This is what we train. We probably have a better understanding of the brain and the medications than any other specialty. So I do think that you will be called on to provide expert advice. But there's help available. With a little effort, you can learn to read the studies. You can learn to understand in rational ways if your treatments are working. So again, track target symptoms, try to understand how things are working. Understand that you're treating target symptoms. You're not treating core symptoms of autism usually. Be cautious and rational in what you do. Keep studying the data. New studies are coming out all the time. Try to help families navigate the path to benefit and improvement, keeping in mind on safety. And finally, here's a few resources I would encourage you to look at as you continue. The Autism Spectrum Disorder Parent Medication Guide and the Practice Planner. These should help on your way. Thank you.
Dr. Lohr, thank you so much for that fantastic presentation. It was really helpful.
Thank you.
Yeah. I'd like to ask you a few application questions to see how we can take the knowledge that you presented and put it into action in our clinical practice.
Yes. Okay.
So the first question I'd like to ask you is, how do you treat ADHD in a child with autism who can't tolerate stimulants?
Yeah, there's a lot of children who can't tolerate stimulants in this population, more side effects, and they may not work as well. And so in this case, we have a couple of results from trials that show that atomoxetine may be helpful and or guanfacine. In fact, atomoxetine has been described by the authors maybe to be a first-line therapy that may be a little bit more useful. Perhaps some less side effects than stimulants and better tolerated. And it seems like in all cases, all these medications work not as well as in a typical population, and they have a little bit more side effects. But they felt like the side effect profile for atomoxetine might be a little bit better. Then with guanfacine, guanfacine sometimes you find being used maybe as a first-line treatment if it's a really young child for whatever reason. It just seems to happen. But there is at least some double-blind support that guanfacine may be helpful as well. So those would be the two things I would think of.
Okay, good. So we have some options.
It can do something, yes.
Yeah. Great. My next question is, what do you tell parents who report that they're treating their children with dietary changes or nutritional supplements?
You know, first of all, I generally praise them or thank them for telling me, because I'm trying to encourage communication and acceptance of what they're doing. I feel like if a physician doesn't know what's happening at home with medication or other treatments, it really puts you a little bit more at risk. And so generally I start with a talk about how there are a lot of reasons that children may develop autism, and we don't know all of them. And we don't know why certain medications work for certain children and some don't. We don't have a lot of data supporting medication use. So, you know, I tell them to be careful. It's okay if you continue a medication in many cases, but try to not make too many changes at once. Try to understand if it's going to be helpful, and just be cautious. You know, there are certain cases, however, that I would say I can't support this. Like, for example, chelation therapy. I've had some parents who talk about getting labs done and then going off to a lab that does chelation therapy. And in a couple of cases, I've had to say, no, I really can't support this. The evidence that I read about this suggests that it's dangerous, could even lead to death. So in some cases, you do have to guide them. But I think that we're in a position to evaluate the evidence in a scientific way to help them decide what's safe and what's not, and to work with them.
Thank you. That's so helpful,
Yeah.
that approach that you use with the families.
Seems to help.
Yeah.
Yeah, I think they respect that open discussion.
Okay. One more question, if that's okay.
Sure.
All righty. When do you decide to start medication like risperidone for irritability and aggression? How long do you continue to treat with this medication, and how do you monitor for side effects in a child with ASD?
Okay, so when I think about starting a medication like risperidone and aripiprazole, I keep in mind these are, I consider them to be pretty strong medications with some significant side effects. So I'm thinking to myself, okay, there has to be a certain amount of severity and risk for me to take this step. So significant problem, irritability or aggression, to the point that maybe safety isn't questioned, or if if they're starting to think about maybe having to hospitalize a child, we'll start thinking about this medication. Or if a child has already been involved in behavioral or other therapies and it's just not working, and the parents are at that point where they're starting to feel desperate, that may be helpful. I think the medications can work really well and can have a dramatic improvement. But I think I try to not use them all the time, because there may be work to be done in behavioral therapies before you use that. I think the bigger question then is, how do you stop it, and when do you stop it?
Right.
They can work so well. I think the parents and families may be reluctant to stop. Even children themselves may say, oh, I don't want to do this. So if you have therapies in place and they've been stable for about a year to 18 months, I will start to talk to them about lowering or stopping the medication and doing it gradually. We'll do this 25% reduction in a dose by 3 months, give it some time, and then evaluate where you are, and just take it very slowly. I think one of the reasons we try to stop is that these medications can have significant side effects. Weight gain, risk of diabetes, prolactin elevation, and even the newer medications still have a risk of tardive dyskinesia based on annual exposure. So it's important to think about that. To manage the side effects like weight gain, diet and exercise can be important, and some medications like metformin may help as well. So.
Great, thank you. I
Yeah,
really
welcome.
appreciate such a thoughtful and comprehensive approach to the prescribing of these medications. Like you said, they're very strong medications.
Yes, thank you.